Well, I think our luncheon speaker provided a wonderful segue for the rest of the day in terms of looking at what Missouri's doing now, looking toward the future and innovation in our Medicaid program. We really wanted a keynote speaker to kind of lay the groundwork for this discussion, and I called around and talked to my good friend from Missouri, Mark Hayes, who's on the Finance Committee, and I said, you know, who on the federal level would you suggest we have come to Missouri and kind of keynote for us in the afternoon? And without missing a beat, he said, I would definitely invite Grace Marie Turner. So I'm pleased to introduce our afternoon keynote speaker. Grace Marie Turner is president of the Galen Institute. It's a public policy research organization she founded in 1995, and she founded it to promote an informal debate over free market ideas for health reform. So we'll have a little different perspective. She speaks and writes extensively about incentives to promote a more competitive, consumer-driven marketplace in the healthcare sector. She's founder and facilitator of the Health Policy Consensus Group, which serves as a forum for analysts from market-oriented think tanks around the country to analyze and develop health policy recommendations. Most importantly, in 1995 and 1996, Grace Marie was part of the Federal Medicaid Commission, and a lot of good work and good thinking was accomplished on that federal commission, and we thought it would be useful to sort of have a review of what that federal commission did and what they came up with, and then we'll dive into a discussion of what we're doing here in Missouri. So please join me in welcoming Grace Marie Turner.
I'm fine. Okay, thank you. Thank you very much, Karen, and thank you, Chris, and thanks to everybody who put this forum together. It's really wonderful to be able to come here and to get in to the Columbia Airport, which had a 200-foot ceiling on the fog this morning. It sort of felt a little like landing on an aircraft carrier. But thank you all very much for coming, for being here, and thank you all for putting this together. I would like to talk about Medicaid and sort of in the context of where we are with the national policy debate, maybe just spend a few minutes on how I think how the climate has changed for the current debate. Is this microphone okay? Can you hear okay? 14 years ago, is that right? 14 years ago when we were having a major national debate over health care reform, I think the political climate was different. There certainly was a sense we absolutely have to cover the uninsured. That was the primary goal of the Health Security Act that Senator Clinton put together. And I think now, yes, the focus is still on the uninsured, but we have a much more worried middle class now. As the cost of health insurance, job-based health insurance for a family of 4 now is about $12,000 a year. Not only are more people uninsured, but many more people are worried they're going to lose their health insurance. And the high cost of health insurance has also really led employers to start fleeing. For the first time this year, the government reported that the percentage of companies that offer health insurance has now fallen below 60%. So the possibility that people will lose their health insurance because of the high cost is really also conjoined with the fact that employers are really worried that they're not going to be able to continue to support these benefits at the same level because the costs are so high. So within that context, we really are starting to have a major national debate over how do we address this problem. I just got back from Europe. I spoke actually at the Vatican talking about healthcare, and believe it or not, they actually had an American come over to talk about the healthcare system. They absolutely believe that we have a permanent underclass of 47 million people who have absolutely no access to the healthcare system whatsoever, and they can't imagine how we can even purport to be a civilized country. And I tell them that we have a lot of problems in our health sector because of the way we structure it. That a lot of people, because we tie private health insurance to the workplace, people are losing their jobs when they lose their health insurance, and we're trying to come up with new ways to make sure that so many people don't fall through the cracks, fall through the safety net, and fall off the cliff when they lose health insurance. But the whole concept of 47 million people uninsured is really a sort of an international scourge that people really think, what are you doing and how can you possibly tolerate this? So I think in a sense, a lot of different forces are coming together to make this debate actually much more vibrant and much more real this time. I really believe that whoever is elected next year is going to come into Washington with a serious agenda on how to, what needs to be done to begin to address some of these problems. I work for a think tank, and so I'm not partisan, but we do, talk with a number of the different presidential candidates to talk about ideas, and each one of them is very serious about coming up with a plan that not only that holds together, you see heads nodding, so you're talking to them too, that holds together, that's scored so we know how much it's going to cost, which is also very different from 1992. When President Clinton was elected, President Clinton won, should we say, President Clinton was elected in 1992, the goal was to do health care reform. Yes, we want to do health care reform. But then when people started to see the details, they said, oh, we don't like that. That's not what we meant. That's not what we want. So this time, I think we're actually going to see a lot of the details during the campaign, and people are going to be able to make a much more informed decision about the structure of this health reform that I believe is coming. One of the things that isn't really very much on the radar screen of the political candidates is Medicaid. And that's why I would like to talk with you today about the experience of our Medicaid Commission, because I think that with leaders like you, that we can begin to get this important program on the political agenda as well. Right now, I think politicians just don't see much gain in it, because so many people think that the only way that we're going to solve this problem is by reducing expenditures on Medicaid so more money is left for other government services. Reforming the program, making it more efficient, certainly is a goal, but how do you do that? And that actually is what our Medicaid Commission did. So I'm going to go down here so I can see the screen and look at you a little bit more easily, and Drew's given me a nice remote mouse so that I can hopefully let the technology work, and we'll go through just a description of what we did with some of our recommendations with the Medicaid Commission. You do have a copy of the PowerPoint presentation, so I'm not going to go through and describe every single one of the recommendations one by one, but just really kind of highlight some of them so we can also have a conversation about what's going on in Washington and how we can make sure that this becomes a bigger part of the political agenda. So I'm going to come down here for a minute. So it's this is Drew and the magic of modern technology. So you can still hear me okay? Good. So the Medicaid Commission was formed. We see what we're doing here? The lectern's blocking the computer. All right, maybe if I stand over here, let's see. Oh, there, that's good. Okay, magic. Thank you very much, Drew. So the Medicaid Commission was established by Secretary Leavitt, 2005, and 15 voting members, 15 non-voting members. I think they figured that, I don't know why they didn't just make everybody a voting member, because the non-voting members had equal participation in the policy conversation. I think they all should have been able to vote at the end, but we had nearly unanimous report, so that showed, I think, that we did work together well. Two governors as the former chairman. The chairman was former Tennessee Governor Don Sundquist, who had inherited TennCare. In 1994, he was first elected. It had already been passed, but tried to figure out how to make this new Medicaid program work in Tennessee. The vice chair was the former governor of Maine, Angus King. Obviously, big states that have been very much involved in the whole health reform debate back even in the 90s, and both of them were very informed. Angus King, an independent, truly, he really sort of embodied that. He had just a really wonderful, fresh sense of coming to policy ideas, and he really wasn't partisan ideological, and it sort of said, this is really what an independent means. I can't stand over there and have this work. So I'm sorry for the TV camera. Several other governors on the program. we held hearings all over the country and also a number in Washington. And every hearing, we had an opportunity for the public to make comments. And that was a really good opportunity, not only to hear from expert witnesses, but also to hear from people who so depend upon this program and their concerns and their fears and the reality of living with Medicaid and the challenges as well as the almost the love for this program that so many people felt. And I think that was important for the commissioners to hear. I'm afraid I may have to go up there. Let's see, let's do this. So we had two mandates. We had our first meeting in late July of 2005, and we had to produce a report by September 1, which was pretty challenging. It was sort of a short-term report to advise Congress on a specific issue of how do you save $10 billion over 5 years in the Medicaid program. And some of the ideas that had been mandated by Congress, and this was our first charge, some of the ideas that we produced became part of the Deficit Reduction Act. And then our final recommendations were due December of 2006, and that was after a number of hearings, as I said. The goal of this commission, and I think really of all of us who were on this commission, was to make sure that this program continues to serve the most vulnerable and needy citizens in the country who really don't have other options, most of them, for health care. And that at the same time, if the program was going to survive and to be able to continue to serve the populations that depend upon it, that we really needed to modernize the program in order to improve both the quality of care and to make the program financially sustainable for the future. So really two goals, making sure that first the safety net continues, but in order to do that, we had to make sure that people are getting the care they need from this program, and that is done in a way that states will be able to continue to support the program. So we had 5 different categories of recommendations, which I will go through on each one of these issues. Long-term care actually became kind of the most important as we began to look at this, because the Deficit Reduction Act created new opportunities for states, including Missouri, to be able to have more flexibility with the program. But long-term care, where the great percentage of the expenses are in the program, was really not addressed through the Deficit Reduction Act. And so Secretary Leavitt actually came to one of our meetings and said, this is what I need you to focus on. You really need to help, because I think if we don't address these issues, that really is going to once again compromise the financial sustainability of the program. And I'll go through each one of these. So not necessarily in order, but the concept, and we heard over and over that, and you all know this, that people want to stay in the least restrictive setting possible. They want to stay at home. They don't want to be in nursing homes. The baby boom generation is not going to go to nursing homes. They want to stay in their home, and we need to find ways to give people new opportunities and new resources to do that. One of the things that was clear to us is that we need to start now. We needed to start 10 or 20 years ago, giving people incentives to purchase their own private long-term care insurance, so that we don't put so many people on this program who could afford to have bought this insurance and are therefore draining resources from a program and people who don't have other options. So we talk now, we need tax incentives for people to purchase private long-term care insurance. We need to be able to support people who are providing care in a home setting in order to be able to continue to do that, so people don't have to go to nursing homes. Letting people use home equity to finance their care when that's a possibility. Make sure that people even understand that Medicare doesn't cover long-term care. It's astonishing to realize how many people believe that long-term care is part of Medicare. Just how people understand that. I don't know what's going on next door, but there is a good time. Alternative insurance, meaning sort of how do you allow people to begin to think of their retirement needs as sort of a package, not long-term care insurance and health insurance and 401ks and IRAs, but to really think of how do you put those resources together in a way that, once again, gives people the greatest flexibility, and then again, allowing care in the least restrictive setting. We heard from a number of states, Vermont particularly comes to mind, that had really done a wonderful job in giving people options to have care in the least restrictive setting. And Vermont, I mean, it's a small enough state that they can practically know everybody by name that's on the program. But they moved toward a principle, I'm Catholic, the principle that we call subsidiarity, which is moving the authority down to the lowest level that you can in order to begin to get the best decisions. To use the resources of the state, to use the resources of the community, to allow the person to do as much as possible for themselves in order to be able to use resources most efficiently. And they not only had huge satisfaction rates with their Medicaid program, their long-term care program, but they wound up saving money in the long run because people were using those resources in a way that was most efficient. And we tried to build some of those ideas into our program. So benefit design, it's supposed to mean flexibility. I mean, I think that the Deficit Reduction Act really, I think at root, that was really its primary goal. How do we give the states more flexibility in order to be able to use those resources and to figure out what do you need? How can we figure out a way to make this program more efficient and make it more responsive to the needs of individuals? What do you think's going on over there? Not Medicaid. Not Medicaid. I'm sorry. I don't know how to do that. And again, allow partnerships between the states and the beneficiaries. One of the examples that I think is particularly good in that vein is cash and counseling. Familiar with this program where patients who are eligible for Medicaid and eligible for personal care services at home, in some states and some pilot projects are allowed to basically use the resources that they would be eligible for personal care, to have someone come to their home to bathe them, to do personal shopping, to prepare their meals, to dress them. But they get to decide who they want to provide those services. One example I thought particularly telling was someone who said, you know, I'm eligible for somebody to come cook my meals, but if I could just buy a microwave, I'd really be happier doing things myself. Someone else said, you know, I could do my own grocery shopping if I just had a ramp on my house to get out of, so I could get out of my house and go the couple of blocks down the street to the grocery store. None of those were, microwaves and wheelchair ramps were not available through the personal care program. But he said, worked with his counselor to say, can we rearrange these finances to be able to allow me to get what I need from this program? It's huge, again, 98% satisfaction. And it may or may not save money, but it's using the resources more wisely so that people get the care they need. And I think another really good example of partnerships between states, beneficiaries, and the federal government allowing these waivers. And then one of our recommendations that the states have more authority to replicate these innovative programs that are working. Emily was talking about this. How do we share information? If something's working in one state and it's really well documented, why should the next state have to go through all the same rigmarole if we know it works in one state? So allow those kinds of sharing of information and piggybacking on other people's success. And we also heard that it's really important for people to know what the new rules are. Allow people to not only find out in advance what the new rules are going to be, but enforce compliance so that everybody is playing by the new public notices and allowing comment periods to be real. Eligibility. That's certainly something that y'all have done in Missouri, is redefine eligibility categories. This was something that we think you need as much flexibility as possible. Once again, moving down, you know your state best. You know your state a lot better than watch some politician and somebody at CMS does as far as what your resources and needs of your citizens are and what your ability is to help them. New subsidies to help working families purchase private health insurance. We felt that in order for the Medicaid program to be sustained for the people who really need the help, we've got to make sure, just as with long-term care, that people don't default into this program who could have other options. Emily talked about premium assistance and premium support. So that if somebody is eligible for health insurance at work, but they just can't swing the copayment, or they can't swing the copayment to put their dependents on the program, they generally just need a subsidy. It doesn't need to mean they need to sign up for Medicaid. They just need support to be able to purchase the private insurance that may be available to them in other ways. So we felt that Congress really needs to address that. And frankly, I think that's one of the reasons that we're having this crazy debate over the state children's health insurance program. The big debate is, the question about reauthorizing the program, there's no debate about that. It's going to be reauthorized. The question is, how high do you take it? Do you take it to $83,000 a year like New York wants to do? Or do we really need to think about how are we going to help people who make too much to qualify for Medicaid, too much to qualify for S-CHIP under current standards, don't have the good high-paying jobs that are going to provide health insurance. These people in the gap are the ones that need help, and that's who we're fighting over. Are we going to put them on public programs, or are we going to provide some kind of new resources for them to get into public and private insurance, whatever their options may be? And so we felt that's really an important thing for Congress to do. And frankly, it's something that's in almost all of the presidential candidates' platforms. So I'd really be looking for this in 2009. I think it's really inevitable, whether it's vouchers, refundable tax credits, premium support, premium assistance, whatever it's going to be called. I think that's very real. In fact, the logo of the Galen Institute is organized around that concept, and I'd be happy to give you my business card in a little while. And actually, I do a newsletter every week, so come get my business card, give me yours, and I'll put you on my electronic newsletter, and you can see our logo. And then scaled match, that was something actually that I offered as one of the ideas, and that is that if New York were to be allowed to put children and families making $83,000 a year on the state children's health insurance program, that means that New York is going to get the S-CHIP match, 66 cents on the dollar, instead of the Medicaid match, 50 cents on the dollar, for those higher income kids. Does that make any sense? That we're subsidizing states for putting higher income kids on public programs at the expense often of Medicaid kids. I don't think it makes any sense. I think we need to figure out how to make those match rates more responsible and more reasonable. And actually, that was one of the ideas in one of the early versions of this legislation. I think it's still there. Not sure. In the version that we got the night before last, that if a state wanted to put children on S-CHIP above 300% of poverty, they only got the Medicaid match. I think that makes sense too. How are we going to use these resources in a way that, once again, gives the most support to people at the lower end of the income scale who don't have other options? Putting children on S-CHIP at $83,000 a year and New York getting a bigger match for them just doesn't make sense. So I think that's also something that is likely to continue to be part of the conversation in Washington. Health information technologies, I think these are pretty much no-brainers. Here are some of the specific things that states, we talked with a lot of Medicaid directors, and in fact there were several Medicaid directors on our commission. Melanie Bella from Indiana, West Virginia, New York, several other states were there. So we really had a sense of what do the states' needs, what do the Medicaid directors themselves need. Allowing a 5-year savings window for information technology investments. That's something that does need to come through federal law, but something that would really facilitate being able to adopt some of these new technologies. including health information technologies specifications and contracts, promoting interoperability. Clearly we need to do that in any case. And then making sure that agencies meet access standards so that people are able to access this information however the electronic medical records may be configured. And these seem like they're so simple. Of course we want information technologies, of course we want quality and care coordination, but what are the policies behind them so that we really can move in that direction? All beneficiaries should be in coordinated care with the medical home. I know that's a major issue in Missouri and something that we heard over and over, that as the healthcare system becomes more and more sophisticated, more and more complex, it becomes more and more bewildering, especially for somebody who's sick. Even if you have access to health insurance, even if you have access to Medicaid, who's going to help you access that system? You need to have somebody who's going to be on your side. So allowing a medical home, state plan options, inclusive participation, streamlining the rules, states sharing in savings from being able to coordinate Medicaid and Medicare. And then I'm going to spend a few minutes in a minute talking about Medicaid Advantage, which was a name we gave to sort of a central idea that we developed and that was adopted by the Commission to integrate Medicaid and Medicare so that we can really begin to do a better job of taking care of duals. And let's see. Other recommendations: establish a national healthcare innovation program, disclose payments to providers. Often they don't know how much they're going to be paid, and beneficiaries don't know that their doctor's only getting, what, $12? What's the average? What is a pediatrician paid to see a child in Missouri right now? I mean, the payment rates are so low, and people don't understand, why is it so hard for me to find a physician? Let's make sure that people know those payment rates. Measuring quality: how on earth are we going to be able to move to a system in which we are valuing quality unless we begin to measure it? So putting in place systems to begin to see, how is this person doing? We're spending, maybe $20,000 to provide Medicaid support for this person in a year. What kind of value is that person getting from that money? Rather than just one payment here, another payment there, this hospital there, this diagnostic, this trip to the even emergency room, these medicines, begin to aggregate those. Medical home is a crucial part of that. So is better information technologies and policies and money that support that. So they all begin to come together to give people many more options. And purchasing quality outcomes, not just services. We heard that over and over. So let's talk a little bit about the Medicaid Advantage program. We believed, and we heard over and over, we've got to do a better job of coordinating care for dual eligibles. They are the ones who are often most vulnerable, most expensive, don't have anywhere else to go. And oftentimes, we heard about a woman who was shuttled between the nursing home and the hospital regularly, different hospitals. And it sometimes would take a week for her medical records to catch up with her, one place or the other. Tests were repeated. They didn't know which medication she should be on. It was terrible quality of care, hugely expensive. How do you begin to deal with that? Do you have the federal government take over care for dual eligibles and just move everybody into Medicare? Do you move everybody into Medicaid? How can the states afford that? Some of the trade-offs were that the federal government will take over the dual eligibles if the states would take over all the other Medicaid population. That just didn't seem to make sense to us because we kept hearing about the success in the states in moving, again, this principle of subsidiarity, moving power and control further down the decision-making tree so that more people had more control the closer they were to the patient. So we came up with an idea to promote this new structure by allowing federal funds for Medicare that are following this patient, and both the federal and the state share of Medicaid funds, as well as potentially even the Part D, the prescription drug benefit money that's coming, and allow those to be integrated into a care management program. So if you're not going to have the money following the person, you're going to continue to have the care fragmented so that the care follows the program rather than the person. So based upon the Medicare Advantage model, yes, there's some issues with the funding, but the idea of people having, again, a medical home, somewhere they can go, that they know that that person knows them or that organization knows it. They're able to collect their medical records. The funding sources all in one place would enable us to do a much better job of taking care of dual eligibles. The federal government has to get over it that it thinks it knows best. It does not know best. We heard too many examples of states like New Hampshire and I know Missouri, if you all have testified before us, of examples of things that you were doing in creative programs, and if you just had fewer strings attached to this money, then you would be able to do much more with it and really be able to reach that care that the person needs in the setting that's most appropriate for them. So Bob Helms, who was one of our Medicaid Commission members from American Enterprise Institute, did a couple of charts to kind of talk about, okay, this is where it is. Clearly the beneficiary is distressed. There's no coordination of care. Payments are coming from Medicaid, Part A, Part D, the state share of Medicaid, the federal match for Medicaid. Should the person stay at home, go to a physician, go to a hospital, nursing home? A different stream of funding follows all of those decisions, and she's in charge. She's got to be the one to decide, now, which specialist should I go to? Which one can I get into? Because there's so little coordination of care. But with a better system of financing, we now have a happy person where you've got the state and the federal money together, pooled together to support this person so that they can get better coordinated care. And the dollars are following the person to whichever system of care is going to work best for them. But it's not going to happen unless we get the money together. It's not something you can just decide we're going to do a better job, because who's going to pay for that care coordinator if the funding is not there to be able to provide this more integrated care? So this idea was really pretty much a centerpiece concept, and I've got a paper I think it's still on our homepage. If not, please give me a card and I'll send it to you. We've been working with Melanie Bella, again, the former Medicaid commissioner from Indiana, who thinks that this is just crucially important for the sake of the program, for the sake of Medicaid, that we do a better job of taking care of people who have long-term care needs. Integrate this funding, give more authority and more responsibility to the states, and allow you to be able to allow those funds to follow the person in the best and most appropriate setting to get the most appropriate care. Cash and counseling that I described earlier is just a little tiny, small example, I think, of what we could do with this program if the incredible resources that we have available to us in this country were better organized and we had a smarter way of spending this money. We've got to get it on the radar screen of politicians. What's next? We've got to bring better coordination to the whole patchwork design of Medicaid. Not only is it 53 different programs, but it's dozens of different programs even in every one of those states. The Deficit Reduction Act does allow you some tools to begin to tailor these programs to your needs, but you need more tools than that, particularly in how the funding is organized. And most importantly, I think we need to create more momentum. Congress doesn't have the vaguest idea the problems that your clients and constituents and patients face when they're on Medicaid. They think, you're on Medicaid, that's fine. It's the most generous health plan in the country, right? Try seeing a private physician. They don't understand the challenges. And I think we need to start helping people understand that it's costing a lot of money, and this program has not been serving the people that it most needs to serve as well as it could. And unless we get more power and control down to you all and down to local, state, and local levels and away from Washington, I think we're going to potentially get into a situation where we wind up with competition for these dollars, and roads and infrastructure and schools and public safety and environmental concerns starts to become a real battle. And unless we can focus on this during this window when there really is going to be a national conversation over health care reform, and make sure that Medicaid is on the agenda and that people understand that we can do a much better job than we have been of serving people who don't have other options. And it means Washington letting go some of those resources and giving you more authority to do that. And I think we have a few minutes for questions. And I'm going to put my contact information up there, and I'll be happy to give you a card. But if you want to sort of stay up with what's happening on these kinds of ideas and policy initiatives, please either send me an email or give me your business card afterwards. And the newsletter's free. I just do it because I want to get the word out. So thank you all very much, and let's have a conversation.
We do have about 5 minutes for questions. Please raise your hand and they'll take you the microphone. Here in the front. Here she comes.
My question is about the Advantage plan. I have some real concerns about that based on some personal experiences that I won't go into as power of attorney, et cetera. My question to you is, would you actually sign up for that yourself?
Oh, absolutely. Absolutely.
If you were on Medicare,
and of course it would be
optional.
This is a Medicaid Advantage plan. If I have multiple chronic illnesses, and right now I don't have a family member to take care of me, and you can tell me that somebody is going to be able to coordinate my care, that they have a contractual obligation to do a good job of making sure that I get the care, that my information is in one place, I'm not going to be shuttled back and forth between nursing homes and hospitals where nobody knows who I am, and nobody's, oh, absolutely. I think that we've got to do a better job of helping to coordinate that care, and that means coordinating the financing. You wouldn't sign up for it?
If it would take away your choices, you would still sign up for it.
It doesn't take away your choices because...
I mean, your choices of providers or services, if the person making the care is making the decisions, that wouldn't be any difference to you.
Every state is going to be different. Well, I think I'm going to have more choices because I'm going to be able to look at the popularity of Medicare Advantage. They're particularly popular among people who don't have the option of retiree coverage. They tend to be people who are not dual eligible but don't have good job-based retiree coverage because they like it, that they can get coordinated care. It's not just an HMO. There are fee-for-service, private PPOs and all sorts of other options to give people, but it's mostly somebody knows your name. Somebody knows your name and they're thinking about how do they do as good a job as possible. If you've got coronary artery disease, you've got diabetes, you may even be starting to have symptoms of dementia. You need people who are expert in taking care of you rather than just saying, well, I'm going to give you a pill for this and a pill for that, a test for that, I'm going to put you in the hospital so we can do this diagnosis. Somebody who's thinking about a care coordination plan. And I don't think you're going to get that unless you have resources following that person. And I think I saw somebody else over here. I see a hand up.
Joe.
We only had time for another question.
Said a few words about fragmentation of care and services, but often fragmentation occurs within a managed care benefit such as Medicaid Advantage, especially when the different parts of the benefit are subcontracted out. The pharmaceutical benefit will go to a PBM contractor, the mental health benefit will go to Medicaid managed care, and often it ends up being more market basket purchasing, group purchasing, as opposed to true management of the person's individual care.
Mm-hmm.
What needs to be done to incentivize that, to overcome that fragmentation?
Mm-hmm. Well, and I think that's when we talked about quality and outcomes. We're not just going to spend the money so that you can go down a checklist. You have to prove that you're actually producing results, that this person's care is actually being coordinated, that you're doing a better job of managing their diabetes, for example. There's some great examples of diabetes care at the special needs plans in Medicare. But diabetes care through the Asheville Project, have you heard of that? City of Asheville, North Carolina. This is not a Medicare or a Medicaid program, but I think a good example of what's possible. The City of Asheville said, we've got to do a better job of taking care of our employees who are diabetic. They partnered with the National Pharmacists Association Foundation, and the pharmacists said, we can do a lot more than just count pills. And their employees would get their medicines for free and their testing supplies for free as long as they visited the pharmacist once a month for just simple little exams. Foot exam, check their A1Cs, check their blood pressure, stuff that they can tell, are you heading for trouble? And if there was a problem, they weren't going to see their doctors. They were waiting until they wound up with a crisis. And what happened with this program is that they wound up with people being better cared for, getting to the doctor earlier so that problems could be addressed. And the system saved money. Those kinds of things could be adopted and integrated also into the Medicaid program. Make it easier for people to get the care they need.
One disease out of many diseases people
Yes,
have. They
right.
usually have congestive heart
Absolutely.
failure and stroke. Why would you want an incentive that only incentivized your insurer to coordinate diabetes?
No.
Why wouldn't you want a global, why would you allow subcontracting a benefit at all is my question. Why should it be allowed?
Yeah, I just use as an example of how you can do a better job of coordinating care. Blow that up to the macro level, in which somebody is responsible for doing a better job of managing all of those chronic care illnesses, and their payments are contingent not just upon doing the services, but upon outcomes. And we're going to start to measure those outcomes. So we're going to see, how are you doing in taking care of those patients? Those are the kinds of innovations, and I believe that the plans would respond to that if the payment paid for it. Right now we're paying for acute care. We're paying for people to have their foot amputated, for crying out loud. Rather than being able to pay them, New York had a wonderful experience with that, where they said, we're going to do a better job of managing patients in advance. The system wouldn't pay for it, so they dropped their programs. We've got to figure out a way to reward people for doing a better job of taking care not just of one illness, not just of one episode, but of the whole patient. And if the money were to follow the person, and the plans or the agencies or, state of Kentucky said, we want to be the manager of the Medicaid Advantage plan, we may decide to subcontract it out, we may not.
That's going to have to be the last word, I'm afraid, on this
Okay.
session. So.
Thank you all very much.
Yeah.